I have some disclosures. I've consulted for AstraZeneca and Roche, honoraria from Merck, and some grant and research support from Pfizer, Merck, GSK. I'm not discuss off-label use or investigational use in my presentation. So hopefully at the end you can understand some of the real-world impact of HPV vaccination as it is today, and to discuss and understand where we might be going with management of HPV-related disease post-vaccination. So Eduardo Franco from Montreal has this slide that dates back to 2006 and talks about the risk factors, which would be sexual behavior. And you get an HPV infection causing a cancer precursor, so you can act with primary prevention and prevent that cancer precursor from happening. You can then do secondary prevention, which is what we do all the time at the present time with screening. We do a Pap test, we do colposcopy, and it's the treatment with a leap in colposcopy that actually prevents cancer from happening. If you don't treat anybody, you don't prevent any cancer from happening. And then you've got tertiary prevention when you're actually getting a cancer, and you may be actually doing screening and detecting a cancer, but you're hopefully trying to prevent death from happening there. But most of our work is on the primary prevention and historically has been in secondary prevention. So primary prevention, we have 3 vaccines available in Canada. We have Gardasil, that's been a quadrivalent 6, 11, 16, and 18, which is used in all the school-based programs to date. I'm not aware of any contracts that have been negotiated to use the nanovalent vaccine, which is the new one, in school-based programs. It was started in 2006 and was followed in 2010 by the bivalent vaccine from GSK. And then more recently in 2015, the nanovalent vaccine, Gardasil 9, has been introduced, and that protects against 6, 11, 16, 18, 31, 33, 45, 52, and 58. And all seem to be very effective vaccines. I'll just go over that briefly. So if you look at this graph that you've all seen before, which talks about HPV types in cervical cancer from Munoz data from 2004, you can see that 16 and 18 covers about 70%, 71% of cervical cancers. But if you add in those types that are in the nanovalent vaccine, the next 7 types, you get down to 87% of cervical cancer. So if we could actually prove that a nanovalent vaccine was effective, we should be able to hopefully prevent up to close to 90% of cervical cancer. In the school-based programs, in Canada, this is data from the cancerview.ca, from CPAC, and they got great resources there for cervical cancer stats. But you can see that British Columbia started in 2008, Alberta 2008, some of us, Nova Scotia started in 2007, and there's various different grades that are vaccinated, whether it be in grade 4 in Quebec, or grade 8 in Ontario, and some of these things are changing and maybe going down to go to 7. I think I read that very recently, and Joan corrected me there. And some are going to two doses, and some are giving HPV vaccination to boys. The nice thing and the incredible thing about Canada is that we actually have data on what our vaccination rates are. And that's become from the school-based program. So we have a school-based program, and you can see province by province, it varies from 58% up to 84%, 88% in Newfoundland. So that's getting 3 doses or 2 doses, whatever is deemed the complete vaccination schedule. We think that's pretty good. We think there's probably some room to improvement there, but it's difficult to get above 80% any vaccination program. When you compare and contrast that to our neighbors to the south, you can see that this is data, and this is data from the CDC, and we think the CDC is an incredible organization. Do you know how they get this data? Well, they cold call homes, and they do a phone survey, and they say, is there anybody in this house that's this age, and have they been vaccinated? So this is US data from a phone survey telling you how much they've vaccinated people. And so you can see that the states that have lowest vaccination rates are in the southeast, Mississippi, Alabama, Georgia, and Florida. And they have seen 17 and 25% 3 doses of vaccine, whereas Rhode Island, up in the top there, has the highest rate, which is nearly closer to 55%. None of these states, obviously, have done anything close to what we're doing in Canada. So when you look at recommendations that come from US bodies, you have to bear that in mind, that they are light years behind where we are in Canada and probably in Europe, because they don't have school-based vaccination programs, and they've got a lot of work to do to get their vaccination rates up to a reasonable rate. So how effective are the vaccines? You've all seen this data. I'm just going to briefly go over it. But the quadrivalent and the bivalent vaccine against vaccine-specific HPV types, the 16 and 18, are between 93, 100% effective, depending on how you calculate the dose, calculate the endpoints. And those protection against those vaccine-specific types lasts for up to about 9.5 years based on some data. So then came the non-covalent vaccine. So Merck decided they could try and add in those extra 7 HPV types to Gardasil to make Gardasil 9. And what you have to do with this data is to add it to that data that you got before, because this is high-grade HPV related to 31, 33, 45, 52, and 58. And you can see that the efficacy is 96% for high-grade infection, cervical vaginal disease, 97%, persistent infection, 96%. And I thought I had 2 slides like that. Perhaps only one. And so vaccines are effective against type-specific associated precancerous changes. So we have very effective vaccines. We have no evidence that we need a booster shot, and young girls are benefiting from that. If you look at when we started vaccination, and this is relevant to your colposcopy clinics, and when we're starting screening, in my province, they're in grade 7. In 2007, when they were vaccinated, and we have about an 75 to 80% vaccination rate that year. So I know if I see somebody who's 22 in the colpo clinic, chances are they were probably offered the vaccine. They may not be able to tell you that, and they're not very clear on that. But next year, you know, the 21-year-olds will definitely have been vaccinated. So you have to bear that in mind and look at where you are in which province and what your vaccination rates are and what you're going to be seeing in your colpo clinic. So how effective are these vaccines? Well, we have data from different parts of the world. The Australians were very liberal with their vaccination policy. They vaccinated everybody up to the age of 26. They did a school-based program. They did a catch-up with the family doctors, and it was all provided by the government. And what they saw initially, and the sort of the condyloma are the sentinel effect of HPV vaccination. They saw a big drop-off of condyloma in young women, the less than 21-year-olds, very quickly from 2007 to 2011. It's almost eradicated in that age group. So they almost eradicated condyloma. They also saw some herd immunity effect, because at this stage they were not vaccinating men. And the men who were the Australian heterosexual men had a decrease in the young age group because they were having sex with those young girls, and there was no transmission. There's a break in transmission going on there. So they've decreased it significantly in that. And if you ask your colleagues in the STD clinics, they say, and the student health services, they say they're seeing a lot less condyloma in this age group. So that's the first sign of things. But what is, for us who are trying to prevent cancer, what is the effect on cervical abnormalities? I haven't seen much recent data from Australia other than this paper from Brotherton in the Lancet in 2011, and they showed that in the young women and the older women, there was no real decrease in low-grade infections, CIN1, CIN2, ascus, those changes. But there was a decrease in high-grade infections in the younger women at that time, and they've not followed that through with a repeat study yet that I've seen. There was a recent paper from Gynecologic and the BC group. It's a little bit small there, but you can actually see that the I can't see, I've got my glasses on. But they saw in the young group of people, they did see observed decreased in high-grade dysplasia CIN2 and greater in BC very early on post-vaccination. It didn't happen in the older women because they'd not been vaccinated and they had the benefit, but the younger women, there was seen there. In the UK, they've done some testing where they've looked at the reduction of HPV types, and they've seen in the younger women, they've seen from pre to post vaccination, they've actually seen a reduction in HPV 16 and 18 pre to post vaccination. And you can see on this graph, when you actually get to 4 to 5 years post vaccination, the prevalence of HPV in the 16 to 18-year-olds, their prevalence goes down significantly from about 17% down to about 3% or 4%. They also saw a little bit of effect on HPV 31, 33, and they were using the Cervarix vaccine at this time in the UK. There is a meta-analysis just recently published from the Quebecois group, I think, I'm not sure if it's Montreal or, but Melanie Drolet published this, and they looked at all these studies in a meta-analysis and a systemic review, sorry, and they saw in the women that were vaccinated with bivalent or quadrivalent HPV vaccines, and the vaccination rate in the country was greater than 50%. They saw a 68% decrease in HPV 16 and 18, and a 61% decrease in anogenital warts. The two papers on high-grade lesions were included, the ones that we just talked about. So, the HPV vaccines have had a real-world impact in decreasing HPV-related disease. They haven't really decreased cancer yet because they've not gone far enough down the line. And they're reducing infections and disease from vaccine-specific HPV types. So how is that going to change what we do on a day-to-day basis? We've made changes to screening in recent years. We've made changes in recommendation and going to colposcopy, and we've decreased colposcopy volumes. What are we going to do in the future? I mean, Canada, screening is a provincial responsibility. We have registries in the province, with some with call and recall. And generally speaking, at the current time, we start at 21 or at sexual debut, whichever comes latter, every 3 years, and we stop at age 70. We don't recommend screening for hysterectomized people. If you go back to 2003, I believe Gavin led a pan-Canadian conference and recommended HPV testing, and that was back in 2003, but it's not been widely adopted anywhere apart from ASCA's triage for women greater than 30 in a few provinces. And in Ontario, Joan came up with the recommendation 2011, trying to stir the pot up a little bit, and recommended that we do primary HPV testing with the reflex cytology, but unfortunately HPV testing still felt to be too expensive and hasn't been widely implemented. But we have to think about where we're going to go with this in the future, and we're probably going to have to go to changing the way we screen and changing the age at which we screen at. I mentioned the Canadian Task Force guidelines, and they actually in 2013, on the basis of conventional cytology, not liquid-based either, I don't recall, recommended that we start at age 25, and didn't really, had a weak recommendation for age 20 to 24. Most provinces chose to ignore that, but that just shows there is evidence for starting at 25, even with, and this didn't even factor in vaccination. So when we screen, in Canada, we do a pretty good job. If you look at all the data that comes from cancerview.ca, we actually get screening rates, hysterectomized and non-hysterectomized women that are close to 70%. And then once within the system, we do a reasonable job about keeping them having a Pap test 3 years later, and then this is the data that shows that combined it's about 80%. And somehow Alberta managed to get 95% of people who've had one Pap test back again within 3 years, and does a great job of that. We then can look at what our abnormal Pap tests are and what the rates vary, and they vary across the country. But in combined, it's about 5% of Pap tests are abnormal, with the blue bars being the low-grade changes, and the darker Prince maroon or purple colors being the high-grade changes. So what we would think we're going to see and what you project you're going to see is you're going to take the top of these things off, and we're going to get a percentage point or two less changes there because we're going to see less high-grade changes. But if we don't change the way we screen, we're going to still end up with a lot of nuisance stuff that's going to fill up our colposcopy clinics. And those of us who do colposcopy, if we go back 20 years, we used to have beautiful, nice, straightforward colposcopy. People had big, thick, white areas on 3 quadrants of the cervix. You could diagnose it easier. Now we're chasing smaller and smaller lesions. We take away the cream of this, I'm not sure I want to be doing colposcopy in 20 years' time unless we find a better way of filtering these patients through the system so that what we see is patients who really need to be there, not the person that's got a 1 millimeter CIN2 lesion that you see the third time you see them and then are obliged to treat them. So that's going to have to change. We're going to have to look about how we screen and how we get to colposcopy to do that. Part of all this is because we know that, and we do have increasing evidence, that screening in young women is not efficacious, and that we detect CIN2. You can argue whether CIN2 exists or not, but I know there's data from BC, and I've got a paper in press, Lou Pickett, and we actually saw regression rates of 73% overall and 78% for women less than 21 who had CIN2 in Nova Scotia. So you find these things in the young women, you don't want to do anything about it. So why are you looking in the first place? And I think they're even looking at CIN3 and BC and about whether we do anything with that or not. So screening needs to be changed. I would suggest that it's going to be HPV-based, and all of the arguments agree with that, so that you actually find those people that have persistent infection with a high-risk HPV type. And if you, post-vaccination, you've got HPV-16 on your cervix, you could argue that you possibly should go straight to colposcopy. Whether we do a secondary test, whether it's cytology, whether it's HPV genotyping and 16 and 18 goes to colposcopy, whether it's fancy testing with P16, Ki67 dual stain, which is done on a slide, or HPV DNA methylation. These are things that are coming down the pipeline that may be the secondary test. So the age of onset is probably going to be 25, but I think it's very soon going to transfer to age 30. Holland has the same cancer incidence as we do, and they start screening at age 30 and only do 10 Pap tests in a woman's lifetime. It's probably going to be every 5 years, and I personally would favor that it's the same test regardless of vaccination status. Keep it simple. Don't make it too complicated for the GP, because they're not going to be able to follow all those different guidelines, and you do not know who's been vaccinated and who's not been vaccinated. What about colposcopy? As I said, I think it's going to change, and part of that is because HPV-16 drives the ship. This is data from Nico Wensenson, who's an incredible researcher at the NCI. If you find a lot of papers that we do in gynecology, he's got his name on them all over the place. And they've done studies where they've looked at cervixes and taken pictures and then taken biopsies and then done laser capture microscopy on those biopsies and seen what HPV types are present in the biopsies. In this cervix, when you took a cytology smear, you saw HPV-16, HPV-52, and HPV-55 on the cervix. So you said it was a mixed infection. And then they took the 4 biopsies from this as part of the research protocol, and they did laser capture microscopy on it, and they saw CIN3 in 3 of those biopsies, all due to HPV-16. So they see that, and you can see how they do this here. This is the biopsy 1 that was negative. It's P16 negative, and then they cut out that piece, and they do HPV DNA testing on it. This one, you could see it's P16 positive, and CIN3, and was HPV-16. And this is the 3rd biopsy, which was HPV-16 and P16 positive. So, and the 4th biopsy. So this compares to this lady that had a cervix, and you can see the lesion there, type 1 transformation zone, some C2-wide areas circumferentially, and it had 42, 53, 55, 66, 67, and 73. And then they did laser capture microscopy, and they saw CIN2 and CIN1. What we don't know is whether those patterns that we see classically, coarse mosaicism, adenosine-C2-white changes, are they all just HPV-16 effects? And if we take that out, how are we going to do colposcopy on those things? I just speculate that that's probably might change. It may be smaller lesions, and they may be more difficult to detect. So you may end up, I don't know, but you might end up with a series of molecular tests, and then you have to treat the patient because you don't know what you're dealing with. But it may be very subtle. And there's going to be less a chance of there being cancer developing if it's HPV 35 or 55 with that. And the same group has done the laser capture microscopy and looked at this and diagnosed it, reviewed it, assessed it, and seen multiple genotypes in the laser capture microscopy regions, but the CIN3 was predominant, and HPV-16 was predominant in the CIN3 areas. So it really drives the boat. So colposcopy is going to be challenging. There's going to be smaller lesions, lower overall volume, and I would suggest that each province and each region is going to have less and less people doing colposcopy. And if you actually follow guidelines, there's probably less need for colposcopy at the present time, but that's another issue. And the same question about other HPV regions. So other cancers that are caused by HPV include cervix, anus, oropharyngeal, penis, vagina, and vulva with varying disproportions, but most of that attribution is due to HPV-16, and so they are going to decrease eventually. They don't have as much screening tests, so they're not going to see an impact on screening, but they eventually will see less disease there. Oh, okay. So we're going to see less cervical cancer, less anal cancer, less vulva cancer. And so in conclusion, I think HPV vaccination has already changed HPV-related disease. Screening and what we do for cervical cancer is going to be modified. Colposcopy will change drastically, and cancer rates will eventually change, and I have no reason to doubt we're going to get breakthrough with the vaccination. Thank you very much.